very honored and fortunate to have with us Dr. Billy Pan, who's an ophthalmologist here in Fullerton, and he's a member of the Terry Eye Institute right here in Fullerton. They do their surgery in association with the St. Jude Medical Center. Dr. Pan is a graduate of the University of Southern California. We don't hold that against him, really. I have two sons that went to Notre Dame, so that's going to be settled here in a couple months. He's also a graduate of the Keck School of Medicine at the University of Southern California. He did his residency at the USC Eye Institute, and he did his fellowship at in glaucoma at the Massachusetts Eye and Ear Infirmary at the Harvard School of Medicine. And he's going to talk to us today about two very relevant issues in people our age, cataracts and glaucoma. So please welcome Dr. Billy Pan.
Thank you very much for having me here, first of all, and thank you very much for being here and giving me your time and attention this morning. I created this talk specifically for today. So this is the first time anyone is hearing this particular lecture. I've given many lectures in the past, but you will be the first witnesses to what could be a great presentation or a disaster. You can let me know at the end. But like you see here, the topic of today will be cataracts and glaucoma. And I'll try to make it as relevant and hopefully information heavy, but entertaining at the same time as possible. So we're going to be talking about two sets of topics for each. One will be misconceptions, things that you might have heard from friends or family, or read in news articles, or watched on TV, and also talking a little bit about surgical advancements, what's available to us in terms of modern technology and what we've been able to achieve in terms of treating or curing these diseases. So once again, my name is Dr. Billy Pan. I work at the Terry Eye Institute, which is local in town. I did train at USC for undergraduate, medical school, and residency. 14 years of my life. I do see there's a pennant over there. And then I went to Boston, and I trained at Harvard Medical School for my glaucoma fellowship. Just so you know, I'm going to try to make this presentation as interactive as possible, just to make sure just to make sure I have at least 50% participation rate by the end. And in order to do so, I've incorporated a lot of photos that I take on travels. I really like photography, and I really like traveling. And the only time I actually get to show these pictures is when I have captive audiences, such as yourselves. So this picture here is actually taken in what's known as the Central Park in Singapore, in this abandoned tunnel. So you're looking up at the trees, okay? So as we go through the presentation, I will stop at certain slides and just ask for feedback to see if anyone knows where some of these photos are taken. I will try to keep this, again, as entertaining as possible, given it is about a 10-hour presentation here. So one interesting fact, people may have seen this before. In 2013, they came out with a study saying that the human attention span has continued to decline from 12 seconds in 2000 to about 8 seconds in 2013, which is 1 second less than that of a goldfish. While I work at Terry Eye Institute full-time, I also am a part-time assistant professor of ophthalmology at the University of Southern California, and I teach cataract surgery to the residents there, and I also lecture to them as well. And if I can get 50% participation by the end of each of my lectures, I consider that a win. So I've done something a little bit different with this presentation, which is I've incorporated a lot of videos, short snippets, about 1.5 to 2 minutes long. So something to break up some of the monotony of just hearing me speak. I've looked through hundreds of videos in crafting this presentation, and I've chosen 9 of the most pertinent information dense but entertaining ones as well. So I've screened through a lot to make sure the ones that I do show you are valuable ones because your time is valuable. I will also say that I forgot to mention, but only 3 of the pictures in this presentation are not taken by me, and I'll point those out to you. So there's 3 not taken by me, you can keep track, and there's 9 videos in total, okay? All right. So last thing before we begin, I have no financial disclosures. Some of the videos do have certain company names. I am not biased or in favor of those particular companies. It's just that I thought those videos had the best information and were the most well-made. All right, so let's begin. Cataracts, we're going to start with the common misconceptions of cataracts. First quiz here, does anyone know where this photo might have been taken? This photo is a little bit gimmicky because I rolled it into a circle. But this is St. Mark's Square in Venice. Okay.
If you have cataracts, you're not alone. By age 40, over 20.5 million Americans will have started to develop cataracts. But a lot of people don't know much about cataracts. Here's how they develop. Cataracts are a normal part of life. You start off with a clear lens that focuses light for clear vision. But over time, protein builds up, then keeps getting denser, until it eventually clouds the lens, making it more difficult for light to pass through and clearly focus. This causes symptoms like cloudy, blurry, or dim vision and sensitivity to light and glare. Cataracts can even make colors appear dull and faded. Symptoms like these slowly develop over time and can end up making everyday activities more and more difficult. The good news is you can correct it with surgery, which replaces your old cloudy lens with a new artificial lens. Cataract surgery is one of the most common surgeries in the country. Nearly 4 million of them are performed in the US every year. And based on a Johns Hopkins report, 95% of cataract surgery patients in the US experienced improvements in their vision. So it's a really successful surgery. Are you ready to get on the path to better vision? Talk to your eye doctor today about cataract surgery and your procedure options.
Okay, just cutting that a little bit short. That was a quick introduction video just to get everyone on the same page, so that we all know what a cataract is. And I'll have a similar one for glaucoma as well, although glaucoma one's a little bit longer because it's a little bit more complex of a disease. But in short, cataracts is when the natural lens of our eyes becomes cloudy with time, and it starts to become opacified, which interferes with our vision. So we're going to treat this as a number of myths that we're going to debunk throughout the course of this morning. Myth number 1, cataracts are caused by overuse of the eyes. This is not true. You can use your eyes as much as you want. Television, movies, reading the newspaper, doing your hobbies. That's not going to affect your eyes. There's one small caveat to that, which I'll mention in a moment. I will say, however, that there are a number of things that can cause or exacerbate or cause cataracts to mature quicker. And this is a relatively comprehensive list, and I'll try to run through it very quickly. Time is number 1. With time, the cataracts in our bodies will harden and opacify. So for the vast majority of our cataracts, time really is the enemy. For patients with diabetes, poorly controlled sugars can cause a quicker onset of cataracts. Smoking has a lot of health-related comorbidities, but it can also enhance the rate of cataract formation. Certain medications, such as steroids, which whether it be oral, topical creams, inhalers, or even eye drops that we give as ophthalmologists for certain conditions, can cause the enhancement of cataracts. Inflammation in the eyes, trauma as well. Certain types of trauma can cause worsening of cataracts. But even if it doesn't cause a worsening of the cataract, sometimes trauma can make the surgery difficult for the ophthalmologist. So if you've ever had any ocular trauma in or around the eye, make sure that your ophthalmologist is aware before they do any surgeries in or around the eyes. And the radiation exposure is probably the most common one that we will face in our lives. Through simply the exposure to the sun and ultraviolet radiation. So the caveat from what I was mentioning earlier is overuse of the eyes. If you are outdoors a lot and you enjoy a lot of outdoor activities, if you are not using UV protection sunglasses, then yes, there's a potential that chronic overuse of your eyes when you're outdoors without sun protection can increase the rate of formation of the cataracts. The last two, metabolic disorders and infections, I put in here just to be comprehensive, but those are usually affecting the pediatric population. I put in this picture here. This picture is representing the UV exposure that causes cataracts. Does anyone know where this might be from? This is Antelope Canyon in northern Arizona, next to Page, around Horseshoe Bend. Okay. This was taken around midday when the sun is right above us. Okay, so cataract myth number 2. Cataracts cause irreversible blindness. So for the majority of people in this room, you probably have a friend, a family, a loved one who had cataract surgery, and they noted that their vision was restored to as better than they could imagine, or better than what they've felt like they've had for a long time. So it is, I think, common knowledge to most of us that cataracts does not cause irreversible blindness, but rather reversible. Once the cataract is out, you restore the vision. This is not necessarily the case for the rest of the world. In a large epidemiologic study about 10 years ago, the rough estimate of the blind population in the world is around 32 million. And where that means they can't see the big letter E on the Snellen chart that we use to check vision. Okay, so that's around 2,400. It's a very big letter. And about a third, 10 million of those are from cataracts, a reversible cause, simply because of lack of access to care. So about 33% of blindness in the world is due to a condition that is completely reversible, but simply because of a lack of affordability or access to surgical care. There are those in third world countries who don't get access to it. A quick anecdote is this particular photo here is a photo that I took of one of my patients when I went on mission trips to India. This particular patient, before surgery, was what we call hand motion level of vision, which means that she can see the shadow of her hand waving in front of her face beforehand. Post-operatively, she was able to ambulate by herself safely, comfortably, and able to return to her daily life. One thing that especially those in third world countries who do have blinding conditions, including reversible ones such as cataracts, is it's not a patient problem alone. It's more of a family problem, meaning that if the patients can't see, their grandchildren are usually their seeing eye people, which means that you're pulling out two productive people out of society, one person because they're blind, the other person because they have to act as that person's walking cane. So with one surgery, you're freeing basically two people to go back to their normal lives and giving children a chance at education. So, cataract myth number 3. Cataract surgery is complex and dangerous. I will put a disclaimer out right away and say that any surgical procedure has risks to it, and you should talk to any surgeon who is going to operate for whatever reason about the full risks, benefits, alternatives panel. But for modern day cataract surgery, with the advancements that we have, cataract surgery is the most commonly done and the most successful surgery that we do in modern medicine. About 3.5 million Americans and 20 million people worldwide will get cataract surgery every single year. And about 98% of those patients will have successful, uncomplicated surgeries in the hands of a skilled surgeon. Okay, that's just some quick numbers, just to allay any fears that the cataract surgery now is anything compared to what it was 40, 50 years ago. It's significantly different, and everything is quite minimally invasive. And cataract myth number 4, cataracts can regrow after surgery. Oh, hold on, I apologize. Sorry, I forgot to mention, this is picture number 1 that I did not take, of 3. This is picture number 1. Cataracts can regrow after surgery. So I think there is a common talk of something called a secondary cataract that forms after surgery. It's a little bit of a misnomer, and it can be very confusing. Essentially what happens is after cataract surgery, your cataract is gone forever. It doesn't come back, okay? However, a film can form behind the artificial lens that we place into the eye, which is what that is, by the way. That is the artificial lens we place in the eye after cataract surgery. Yes?
You mentioned this complex surgery, and I've heard, and I know about laser versus other cataract surgery. Is that a significant medical benefit to go with a laser surgery?
That's a great question. The question is, there is information now about laser-assisted cataract surgery in addition to the surgeries that we've been doing before. Laser-assisted cataract surgery has not been proven in numerous studies to show any significant improvement over cataract surgery prior to it. In very rare circumstances, in certain complex types of cataracts, it can help. But for the vast majority, 99+% of patients, it really doesn't do much. So the film that forms behind the lens that causes decline and decrease in the crisp vision that you experience after cataract surgery is something called posterior capsule opacification. In short, it's called PCO, but this is also what's known as the secondary cataract that you might have heard of. So what happens, so what do you do when this happens? We perform something called a YAG capsulotomy, which is a big word, but all it means is that we use a laser procedure in clinic and we clear away that film and we restore the clarity of the vision that you had immediately after cataract surgery. So this secondary cataract, so to speak, happens in up to 50% of patients, usually within months to years after the original surgery itself. And again, the laser procedure itself is very quick. It takes about 5 minutes in clinic and it's a painless procedure. Now, once again, the cataract surgery, when it's done, cataract is gone. It's a one and done type of situation. If this secondary cataract or the PCO forms and you get a laser, again, it's a one and done procedure. It also doesn't come back. And there's no such thing as a tertiary cataract. So if anyone ever mentions that, they are trying to cheat you out of something. This is also a picture that I did not take, but I thought it was a great photo showing regrowth. So this is number 2 of 3. Okay, so I have basically 4 what I consider myths for each glaucoma and cataract. So we're finished with the cataract portion. We're going to move on to the latest surgical advances, okay? And for each of the ones in the surgical advances, I'm essentially showing a brief video clip about a minute to a minute and a half long, so you don't have to hear me drone on. You can watch something instead, hear a more pleasant voice. Does anyone know where this is? Chicago, yes. This is the Cloud Gate, or the Bean, in Millennium Park. If you look at the very center, you see 4 people there. This is what I considered a quote-unquote selfie. I am one of those people taking the photo there. Okay, so modern cataract surgery. One quick video after each of these, and we'll talk about the video just a little bit.
As you may know, cataracts are a natural part of life. But did you know there are nearly 4 million cataract surgeries performed in the U.S. every year? Let's discover some other helpful facts about cataract surgery. Cataract surgery is one of the most common procedures performed in the U.S. today. The surgery itself typically takes about 15 minutes, with an additional 1 to 2 hours to rest in the surgery center immediately after the procedure. Think of the procedure like replacing a frosted window. If you can't clean away the frosted cloudiness, the window becomes difficult to see through. A cataract-clouded lens in your eye works in the same way. During cataract surgery, the surgeon removes the cloudiness by replacing the lens, just like you would replace a window pane. With the new window pane in place, you can see clearly again. After cataract surgery, your vision will be clearer and brighter. And the good news is, you may be able to correct other vision issues, like astigmatism or presbyopia, during the surgery with different replacement lenses. These types of replacement lenses can even reduce your need for glasses. Most people take 1 or 2 days to recover after surgery, but make sure you ask your doctor about activities that are safe and about the risks involved in the procedure. Get to know your replacement lens options and how you can clear away the cloudiness of cataracts. Talk to your eye doctor about the risks and benefits of cataract surgery to find out your surgery options and what replacement lens could be right for you.
All right, first of 3. bear with me. As I'm listening to this with you, I realize I'm just forcing you all to listen to commercials on your free time. The quick few comments about modern cataract surgery. It's becoming increasingly more minimally invasive, meaning the wounds are becoming smaller, the instruments are becoming more delicate, the energy we use to remove the cataracts is becoming substantially less year after new developments occur. In short, the surgery itself takes about 10 to 15 minutes. The whole process takes probably a few hours, an hour before, an hour after surgery for pre-op and for post-op to make sure that you recuperate from the anesthesia. You are awake the entire time, except for certain rare circumstances, but you're awake the entire time, but the anesthesiologist who's next to you the entire duration of the surgery will give you medications through an IV that essentially makes you comfortable, a little sleepy, a little drowsy, but well rested as the surgery is going on. You notice a bright light for the duration of the surgery, but you feel nothing, and you don't have to do anything. Okay? The recuperation time for most patients is about 48 hours, and most patients are back driving and doing their daily activities just at a slightly lower level of strenuous, a little less strenuous during that initial first week. Okay. All right. So the prior video talked about two other things. Two of the things that we have now available to us in terms of cataract surgery is in terms of the lens developments. We have two types of lenses, which I'm going to show two videos for. One corrects for astigmatism. Now, for about 50% of people in this room, you will have no idea what astigmatism is because you've been blessed to not have astigmatism in your lifetime. However, the other half of the people in this room, myself included, we have astigmatism, and it causes distortion in the quality of vision unless we correct it with either glasses, contact lenses, or in modern cataract surgery technology, lenses that are placed in the eye that can counter the astigmatism intraocularly through the device that's implanted in the eye. So, quick video.
Did you know, by the time people turn 65, 90% will have started to develop cataracts, and around 52% of cataract patients also have astigmatism. With so many of us potentially affected by these two conditions, let's learn more. Cataracts and astigmatism both affect how light passes through your eye, but cataracts cloud your natural lens and block light, while astigmatism prevents light from focusing on the retina. Astigmatism means that the cornea is shaped more like a football, instead of being rounded like a basketball. This is why light can't properly focus, and your vision is blurry if you don't wear your glasses. Fortunately, there's a way for you to correct both conditions with one procedure and improve your vision by selecting an astigmatism-correcting lens for your cataract surgery. This is because its unique design corrects the blurriness of astigmatism and replaces your naturally cloudy lens. After the procedure, your vision will be clearer, brighter, and less blurry, and you may even reduce your dependency on glasses. Your lens choice is important, especially if you want to decrease your dependency on the glasses you wear to help correct your astigmatism. Better vision starts with a conversation. Talk to your eye doctor today about opportunities to fix cataracts and astigmatism with one.
All right, so I promise you that is the last video by this particular company. I know they've all looked very similar, and there's been a little bit of redundant information, but I thought the information was valuable, so I did include multiple of their videos. So astigmatism is, so that's a little bit about astigmatism correction. It's something that we can offer with lenses that we have now. The last one is something called the depth of field. Now, before I show the video, I'm just going to try to address what exactly depth of field is, because it's a little bit of an enigmatic concept until, because we don't usually think about it. Normally, when we look at a certain target, we can see objects in the distance clearly, but if we need to see something up close, our lenses in the eyes, they actually have to change shape. Now, with time, as the cataract develops and it hardens, it can no longer change shape, which is why readers start being a necessity almost past the age of about 40 to 45, going from low ad 1+ cheaters to 2+ to sometimes 3+, depending on how your own eyes are. So with time, because the lens hardens in our eyes, which is what a cataract is, a hardened lens, it doesn't adjust, it doesn't change shape, so it can't focus in different planes or depths of field. So the 3 depths of field that most of us can relate to would be distance vision, which is a vision we use to look at anything in the distance, which includes driving vision mostly. What we can consider intermediate distance, which is at least a good arm's length, if not a little bit further away. And for most patients, this is computer level of vision. And then we have near vision, which is what we use when we look at our phones, an iPad, a book, a newspaper, a magazine. So 3 depths of vision. With our native lenses, our natural lenses that we're born with, it changes shape enough that we can look through all these depths of field as well as everything in between it with ease because our lens changes shape. But as time develops the cataract, that cataract no longer can change the shape and we can no longer focus on multiple planes. The cataract, the intraocular lenses that we offered before can be targeted for one of those 3 planes. You can target it for distance, intermediate, or near. Most patients choose distance. But in more recent years, there have been lenses that allow more what we call spectacle freedom or independence, which allows a patient to be able to see distance and intermediate pretty darn well, and sometimes even up close at near. So this video is going to show a little bit what that's about.
During cataract surgery or lens replacement surgery, your eye care provider will replace your eye's cloudy or inflexible lens with a new intraocular lens, an IOL. The goal of the IOL is to give you the best visual outcome based on your lifestyle and your eye's shape and health. While there are many IOL options, some, like the monofocal lens, will only correct vision at one distance and may require you to wear glasses at other distances. Other IOLs allow correction at multiple distances, but require the eye to refocus when shifting between each distance. New extended depth of focus IOLs provide a continuous full range of vision, allowing you to see clearly at near, intermediate, and far distances, and to change focus comfortably. This is especially helpful for people who have presbyopia, the gradual inability to focus up close, and who would like to reduce their dependency on glasses. There is also a version available to correct astigmatism.
Okay, so I cut that video a little bit short, kind of droned on a little bit more, but the information that was presented I thought was the pertinent part. Okay, so that actually ends the cataract portion of this talk today. I kind of built in a mini break to solicit questions to help wake people up if anyone's asleep. Yes.
I have a question. If a person has a lens and it affects the macula, causing wavy lines, can you address that?
That's a great question. The question is, if there is a macular-related issue, which is a part of the eye in the back that collects and senses light, if the IOL, the intraocular lens that we place during surgery, can correct for this. Unfortunately, it cannot. Pathology unrelated to the cataract itself really cannot be addressed by the intraocular lens. So macular degeneration, glaucoma, none of these things can be fixed by the lens, but those are pertinent things to bring up to your ophthalmologist because certain types of lenses are not appropriate for patients who have glaucoma and have macular degeneration. Yes?
A couple of your slides showed that cataracts are caused by protein buildup on the lens. So I was wondering if a high or low protein diet, particularly at extremes, affects the incidence of cataracts over a lifetime.
It's a great question. So the question is, does a high or low protein diet affect the formation of cataract? So the videos did show before that cataracts are caused by, I think they mentioned buildup of protein. That's a little bit that's not exactly what's happening. Our lenses are actually created, they're essentially water and protein. They're built as water and protein. What's happening in the lenses is that these proteins start to aggregate and to clump together. And when those proteins start to aggregate and clump together, that's what's causing the cataract. So that's the first part of the question. The second part of the question, does a diet low or high in protein affect cataract formation? The answer is no. No diets have been shown to worsen or improve or reduce the formation of cataracts. There are some that have been studied which have shown potentially some benefit, but nothing has been really nailed down. For example, vitamin C, vitamin E, beta carotene, those are things that have been thought may be helpful because they're what we call antioxidants, and oxidative stress can increase the formation of a cataract. But large-scale studies done by the National Institutes of Health have not shown that even vitamin supplementation can help. That being said, leafy greens are always good, and there are some vague reports of having of high cholesterol being potentially worse for the formation of cataracts, but again, relatively circumstantial.
A supplement like lutein?
Lutein is great for patients with macular degeneration, but it doesn't affect the formation of cataracts. Yes?
Your thoughts on bilateral cataract surgery the same day?
As far as I'm aware, bilateral cataract surgery is done the same day is only done at this time in the US in the Kaiser system. They're actually still building data, and they haven't published it yet. But it's not so much of it's more of a safety issue, because with any surgery, there's a risk for infection. So if that infection happens, we always want to address it and make sure the eye is stabilized before we even consider the other eye. Now, if you do two eyes at the same time, if they both get an infection, then that leaves that person incapacitated for an extended duration of time, which is why bilateral surgery for the vast majority of surgeons is not something that we're comfortable with. Yes, please. Mm-hmm.
Did they used to use donated lenses before they had artificial lenses?
They've always had artificial lenses. There was a period of time where they did not put a lens in at all, so patients would wear very thick glasses or contact lenses. But what you may be thinking of is a donated cornea. Patients who need corneal transplants need,
That's it.
correct.
And then my other question is, if you don't have cataracts, would you recommend having astigmatism, having the lens changed just for that?
So what you're talking about is the question is, if you do not have a cataract, but you do have astigmatism, is it worthwhile getting the lens changed just to fix the astigmatism? I don't recommend it. I recommend getting cataract surgery when it actually starts to affect your vision and quality of life. In the back.
If you've had cataracts removed and a lens put in, what's the time period in progress of the lenses? Is there a point at which they didn't have it correctable for astigmatism, and if I had one of those lenses, would I want to go back in and have a different lens put in?
The question is, what is the rate of development of lenses and new technologies for lenses, which is a great question. Roughly on the order of every 10 years, you'll see some kind of new big development in intraocular lens technology. Are we at that 10-year cusp? No idea, unfortunately. These are trade secrets that are kept by the companies pretty closely. But I guess my answer to that question is, if the cataract is bad enough and you and your ophthalmologist together can decide whether it's bad enough. You based on your symptoms, your ophthalmologist based on what they see on your exam. Then I would not wait necessarily to see if something better shows up, because even if they do, they're relatively incremental changes from what we have currently. And if you had a cataract surgery before with an older lens, should you get the newer lens? The answer is no. Going back in to remove a lens is a fairly traumatic surgery that we don't like to do unless it's absolutely necessary. Yeah.
What if you have pterygium? I don't know. Do you need to have that taken care of before you have cataract surgery?
That's a great question. There's something called pterygium, which are these little nodules that grow on the nasal parts of the white of our eyes, caused by sun exposure. And the question is, do we have to take care of that before cataract surgery? The answer is, it depends. If it's a very bad pterygium, yes, ideally we should take that off, let the cornea heal to see how things are looking at that point, because pterygium can cause astigmatism. So if it's causing a lot of astigmatism, we should remove that first to see where the eye heals to. If it's not so bad, if it's relatively small, we'll usually just watch it. I think it is.
You said that astigmatism can be corrected during cataract replacement of the lens. For some cases, can you make a statement about which astigmatism can be fixed and which can't?
That's a great question. The question is, what types of astigmatism can be fixed? What we consider to be regular astigmatism can be fixed. What that means is based on the imaging information we take of your eye. When we plan for cataract surgery, we measure the length, the width, the volume, the size, the contour. We basically create in our minds a 3D, almost like a 3D visualization of your eye. Depending on how your astigmatism is shaped, we can see that on the scans that we do of your eyes. And there are certain types of astigmatism that are not amenable to intraocular lenses that correct it and can actually make them worse. So you have to make sure with your ophthalmologist that you have what's called regular astigmatism. That's the type that benefits from toric intraocular lenses.
I wanted to ask you, on contact lenses, could you have one eye for distance and the other contact lens for closeness?
Yeah. So the question is, can you have one eye targeted for distance and one eye targeted for near so that you can see both distance and near without having to put on glasses? And that's called monovision. And it's done by a number of patients, although that number is fairly small, because to be able to tolerate distance vision and near vision can be a little disorienting because the magnification of images is different and the eyes are not working together, and you lose binocular vision and you lose depth perception. For all of those reasons, it isn't what many patients are unable to tolerate it, but for those who do tolerate it, they go on very well with it. All right? All right, so thank you very much for those great questions. Really fantastic questions. I am going to move on to the glaucoma portion. Before I move on, does anyone know where this is? Yeah. This is Italy, Cinque Terre, one of the towns in, I think it was pronounced Cinque Terre. Yeah. All right. So glaucoma, I'm gonna jump into some of the misconceptions first. I have a short video. I will say it's the longest of the videos in this presentation. It's about 4 minutes. The level of the video is really targeted to a medical audience, but it was such a good video, so concise, filled with excellent information, and it was the best one I found out of looking at about 50 different videos that I really thought it was worthwhile to show. If you get lost during it, it's okay. It's because the level of the video is fairly high. But I will pull a few important salient points at the end of the video so we're all back on the same page. Okay? This is a picture of the roof of the Museum of the Vatican. Okay? Looking up the spiral staircase.
Glaucoma is actually a group of eye diseases that are usually due to intraocular hypertension, or increased pressure in the eye, which damages the optic nerve and, if left untreated, can lead to blindness. Taking a closer look at this cross-section of the eye, you can see that it's split up into different chambers. The anterior chamber includes the area from the cornea to the iris. The posterior chamber is this really narrow space between the iris and the lens. And then this larger vitreous chamber includes the space between the lens and the back of the eye. Not to be too confusing, but both the anterior and posterior chambers are located within the anterior section of the eye, while the vitreous chamber is part of the posterior section of the eye. Typically, each of these chambers is filled with fluid. The chambers in the anterior section are filled with a liquid called aqueous humor, and the posterior section is filled with vitreous humor. The aqueous humor is a transparent, watery fluid that's secreted by the ciliary epithelium, which, in addition to secreting aqueous humor and providing nutrients to the lens and cornea, it provides structural support and helps to keep the shape of the eye. So that fluid's secreted into the posterior chamber, and then flows through a narrow space between the front of the lens and the back of the iris through the pupil to the anterior chamber. From there, the fluid flows out of the eye through the trabecular meshwork, which is a spongy tissue that acts like a drain. And this allows the fluid to go down into a circular channel called the canal of Schlemm, and finally into the aqueous veins, which are part of the episcleral venous system, the veins around the sclera of the eye. In glaucoma, part of this aqueous humor drainage pathway becomes partially or completely blocked, so that fluid can't easily drain out. This causes the pressure within the fixed space of the anterior chamber to quickly build up, causing intraocular hypertension, which is defined as pressure greater than 21 millimeters of mercury, or 2.8 kilopascals. This high pressure affects all the structures of the eye, including the optic nerve, which is the nerve that carries visual information from the eyes to the brain. And this means that over time, as the optic nerve gets damaged, glaucoma leads to vision loss. Now, there are a couple types of glaucoma. First, there's open-angle glaucoma, which is actually the most common, and it has this name because the angle between the cornea and the iris is open. In this type, the drainage system slowly gets clogged over time, and so there's this gradual increase in pressure on the optic nerve. This increase in pressure initially results in atrophy of the outer rim of the nerve, resulting in a decrease in peripheral vision. As that pressure increases even more, though, there's continued damage to the optic nerve, which eventually leads to a loss in central vision as well. Another type of glaucoma is closed-angle glaucoma, also known as angle closure glaucoma or narrow-angle glaucoma. And this is due to the angle between the iris and the cornea being too small, meaning that the passageway for aqueous humor outflow is too narrow, and this is as a result of the lens being pushed against the iris. The result of this is that the drainage system gets blocked again, but this time causes a rapid buildup of pressure within the eye, which can cause abrupt onset of severe eye pain, eye redness, blurry vision, headaches, nausea, and visual halos. Finally, normal tension glaucoma, or low tension glaucoma, happens when the pressure is normal in the eye. The cause of normal tension glaucoma is largely unknown, although it's thought that the optic nerve becomes damaged due to hypoperfusion, or poor blood flow, as well as potentially genetic hypersensitivity to pressures that are even in the normal range. For diagnosis of glaucoma, tonometry can be used to assess for increased intraocular pressure. Also, though, visual field testing can be done, as well as looking for optic nerve damage, either through imaging or by direct observation. In particular, that pressure on the optic nerve results in a thinning of the outer rim of the nerve, which starts to give it this cup shape, and this is called cupping, and it's often seen in individuals with glaucoma.
Right. So, sorry for that long video, and I know it was a lot of information, but glaucoma is a very complex disease, and it's not as easy to describe what it is as it is to describe what a cataract is. A cataract is a dense lens that you can't see through, but glaucoma, it's complex, and even patients with glaucoma who have been treated for glaucoma for a long period of time, they sometimes don't understand the nuances of it. Anytime I describe glaucoma for the first time, what I describe it is essentially this. Our eyes are basically like sinks, Okay, we have a faucet that comes in, and we have a drainage system, a piping that leads out. Okay, however, unlike a normal sink, for example, if it overflows because the piping is clogged with hair, debris, junk, it can overflow. But in our eyes are a confined space, so it's a closed box essentially. So our eyes are like a sink, but it's actually a closed box with an input and an output. That output, when it blocks up and slows down, does not mean that the faucet coming in slows down. So what happens is the pressure in the eye builds. It builds gradually over time, but as the piping becomes more and more clogged, then the pressure builds faster and faster and faster and higher and higher and higher. So that's what builds up pressure in the eye, and that extended pressure damage in the eye can cause what we know as glaucoma. Now there's multiple types. And I'll go into each of them in just a little bit of detail on one of the ensuing slides. Actually, I think this slide here. Again, it's a complex system. What happens with glaucoma in terms of the vision is at first you start losing peripheral vision. So it's not uncommon for patients to not notice they have glaucoma at all until they're regularly scheduled screening and the eye doctor says, hey, you have the early signs, or ideally the early signs of glaucoma, or sometimes it has happened where a patient comes in and we're seeing glaucoma at its very worst. That has probably been going on for years and years, and the patient still has 20/20 vision, but they're looking through a very, very small amount of vision just straight ahead. They have lost everything around 360 degrees. So those are the cases that we don't like to see, and we try to prevent by advising regular eye screenings yearly after the age of 50. Okay, so glaucoma myth number one, glaucoma only occurs with elevated pressure. Now this is a little bit of a tricky, this is part of the reason why glaucoma is a really complex disease. So what is quote unquote normal pressure in the eye is between 10 and 21. Now how they define that is they found the average pressure in the eye, which is about 15.5, and they went 2.5 standard deviations above and below, which captures 95% of the population. And that is basically 10 to 21. So 95% of the population falls within those pressure ranges. Okay. However, that does not mean that you can't get glaucoma if you are in the quote-unquote normal range. And it also doesn't mean that you have glaucoma if you are above that range either. Okay, which also makes the situation a little confusing. Furthermore, there's something called diurnal variation. What that basically means is that the pressure in the eye can change throughout the day. We know based on studies measuring patients every couple hours throughout a 24-hour cycle, including waking them up in the middle of the night, that the pressure in the eyes is the lowest in the early 1/3 of your sleep cycle, in the early AM hours, 1 to 2 a.m. And it starts to climb up and hits a peak around 6 to 8 a.m. Basically, it follows the cycle of a hormone in our body called cortisol. Cortisol is our stress hormone, and it goes up, and it hits its peak at around 6 to 8 o'clock in the morning because that's what gets us up and ready to face the day. Sometimes mine is not enough, so I drink coffee, but it usually follows that cycle. So it's lower in the evening, hits a peak in the morning, and then it wanes as the day goes on. Okay, so if you are seeing your doctor and you are getting a normal pressure reading that at once, that doesn't mean much because potentially at another time it could be a little higher. Okay, so the quick review of what types of glaucoma there are. This is a very dense subject. It requires really a specialist level to understand and treat, but you have what most people know as just the normal bread and butter glaucoma with your high pressures in the eye. Okay, this is called open angle high pressure, high tension glaucoma, which means that the drainage system, when you look at it, it does not look blocked. So when you look at your kitchen sink, if you have an overflowing kitchen sink, but there's no stopper over the drainage system, you know that the piping is bad. That's what's happening here. You also have open angle low tension glaucoma. The thought is that the pressure is in the normal, quote unquote, normal range, but these patients are not suffering so much as from the pressure damage as they are suffering from the fact that the optic nerve, the nerve that connects our eye to our brain, isn't getting a good blood supply. There's also closed angle glaucoma. This is when you look at the drain and you see that there's a stopper on there. That's what's causing the drain, that's what's causing pressure to build. This is the type that can cause sudden onset of really bad unilateral, meaning one-sided pain that sends patients oftentimes to the emergency room and often gets misdiagnosed as a stroke. There's also something called ocular hypertension where the pressure is above 21, above the normal range, but patients don't have glaucoma, which is, again, confuses the picture a lot. And then there's also patients who are known as glaucoma suspects, meaning that the anatomy of the eye looks like you have glaucoma, but everything else about you says that you don't. And again, it really takes a specialist who's been trained on glaucoma, in glaucoma, to catch the suspects, the early stages, those and the ones that are easily missed, right? Because if you do have glaucoma, you want to treat it, you want to catch it as early as possible to make sure that it does as little damage as possible and that you control everything as early as possible, okay? So that is myth number 1. Again, a lot of information here. These are a little bit more information dense than cataracts simply because it's a more confusing subject. This picture here is on the way to the Grand Canyon, just on the road, driving in the middle of the night, Milky Way up in the sky. Had to stop for a picture. Okay, so myth number 2, diagnosis is blindness. That's not true. In the past, when a patient was diagnosed with glaucoma, it oftentimes did mean inevitably that patient was going to go blind because treatment modalities was not robust in the past. However, that's not the case now. We have a lot of great advances, okay? So while glaucoma is not curable, it is eminently treatable. So anytime I see a patient with newly diagnosed glaucoma, I tell the patient there's never a good time to be diagnosed with glaucoma. Nobody wants glaucoma, but if I were to be diagnosed with glaucoma, I would want it to happen now. And just to give everyone a sense of why that is, in terms of medications that we have to treat glaucoma, we've had the same medications to treat glaucoma for the past 20 years. And they're good medications, don't get me wrong, but we haven't had any new developments for the past 20 years. But in 2018 alone, we've had 2 brand new FDA-approved agents, 2 medications that are fantastic for glaucoma treatment. These are not just a fancy repackaging of old medications. These are brand new medications that target different pathways in glaucoma and have had profound effects in patients who qualify for them. Additionally, the surgeries that we used to do for glaucoma often incapacitated a patient for months at a time because the surgeries are quite invasive. So if ever the patient's medications were not controlling the disease well enough anymore and they had to undergo the knife, they could fairly consistently count on that eye not working well for about 2 to 3 months' time. However, in the past few years, we've had an onslaught of development of what we call MIGS, minimally invasive glaucoma surgeries, which I'll be showing you in the latest advances videos. And these give us a buffer between when medication fails and when we need the big gun type of surgeries that incapacitate patients. We have something in the middle now that works well, and patients are out for, instead of months, weeks, and sometimes even days. So we have something in between when we didn't have anything before. So glaucoma is very treatable, and the goal for me, for every single patient, is to develop that lifelong relationship, because glaucoma is a lifelong disease, till death do us part, that we need to make sure that the vision stays until the very end. Okay, this picture is, there's a museum in Los Angeles called The Factory. It's called the Factory Museum, and this is one of their art installations. It's just an open room with a bunch of pitchforks hanging down. The message of this is, diagnosis does not mean you're just taking blindness with it. Okay. So glaucoma myth number 3, there's nothing that I can do once I'm diagnosed with glaucoma. That's not true. The things that you should definitely do include going to all of your glaucoma visits. For my patients who have glaucoma, if you're rock solid stable for years on end, I'll probably see you 2 times a year. If you're reasonably stable, I'll probably see you 3 times a year. If you're unstable, I may be seeing you every single month until we stabilize you, okay? So sometimes this can become an annoyance because coming to me monthly seems way too frequent. But if I'm seeing you monthly and I think I need to see you monthly, it's because it's important and not because I'm bored. I really need you to see me so we can make sure that the eye is progressing at a good, is not progressing rather, and is stabilizing at a good rate, okay? Number 2, using your eye drops. Very important because compliance with medication is the means by which we control glaucoma for most patients. This doesn't mean that if you don't tolerate the side effects of the drops, or you're simply unable to give yourself drops sometimes 3 times or 4 times a day, that I'm gonna force that on you. No, we have alternative options. If you're telling me that we can't do it, then we find something else, okay? That's why we have surgeries, we have lasers, we have other options, okay? What I don't want you to do is for 6 months of the year, you don't use the drop, and then 1 week before the appointment, use your drops religiously. It's like when I go to my dentist, I floss the week before, and I'm just kidding, I have excellent oral hygiene. Because at best, it just confuses the picture, but at worst, it makes things, it actually really muddies the treatment algorithm. And what I mean by this is, if I see a patient who doesn't use their eye drops for 6 months, and then the week before they start using their eye drops and their pressures are beautifully controlled, but I look at their eyes and I can see that their glaucoma is progressing, that means, in my mind, that they're progressing at an excellent pressure, which means that we have to lower that pressure even more. But when the pressure is already very low, it takes very aggressive surgery to get it even lower. Little did I know that patient was probably running at actually a high pressure where they were suffering all of this damage, and I'm seeing an artificially low reading. Okay, so that has happened before, which I've caught early. And once we get them on the correct regimen that they're using consistently, then we don't see that, okay? If drops are not something that is tolerated, we can do lasers, which we do in the clinic. Very minimally invasive, and there's no pain, takes about 5 minutes. And again, if the lasers aren't enough to control it and the drops still are not effective enough, not tolerated well enough, difficult to use, some patients have a very difficult time getting drops in their eyes, then we can do, again, some of those minimally invasive glaucoma surgeries that require days to weeks to heal and try to get you off of drops completely, if we're lucky, okay? Last one here is blood pressure management. For the low tension type of glaucoma, the one where the pressure is actually not high, it's in that quote-unquote 10 to 21 normal range, these are the patients where we are concerned about blood supply to the nerve is not robust enough. And in those patients, we recommend that if you take blood pressure medications, you take it in the morning, because when you take it at night, it drops your blood pressure even more. And so during the evening, the blood pressure being as low as it is can compromise the blood supply to the nerve, okay? Medications for blood pressure are often given at night by primary care doctors because it can cause this low blood pressure, and if you're sleeping, you won't feel the side effects of it, okay? So when you take it in the morning, sometimes patients feel a little bit dizzy, a little bit woozy. So in these circumstances, we kind of have to weigh the side effects of the medication with the potential of worsening of glaucoma if you take it at night, okay? Things that we talk about on a case-to-case basis. Question?
What about exercise?
Exercise is always good. There's a little bit of conflicting studies on exercise. Some say that too much exercise can be bad, but those studies aren't, they're not foolproof studies, and there are some studies that say exercise is good. So when you have reports and journals, studies saying different things, then the answer is we don't know. And just a few more things that are a little bit sillier, but things to consider, really. Excessive coffee intake. I drink about 4 to 5 cups a day. We know that if you drink above 5 cups a day, it can start affecting your eye pressures. 1 to 3 is pretty tolerable. Excessive fluid intake. What this means is you're ingesting liters of water in a short period of time, in under an hour. What this does, it increases the overall volume of the body, which also increases the volume in and around the eyes, which also increase pressure. So if you drink fluids, which you should, spread it out throughout the course of the day, right? Multiple glasses, 6 to 8 a day. Yoga, doing headstands is not good. But even doing downward facing dog is not great, because anytime your eyes are below the level of your heart, that can increase the pressure of your eyes. Okay, that's not to say don't do yoga, it's just something to consider. And another silly one is they've done a lot of studies looking at musicians who professionally play wind and brass instruments. Every time they're puffing on their instrument, the pressure of the eye spikes up, right? Okay. That picture, anyone know where that one's from? Florence, yes. Question?
High impact sports impact on eyes, collisions that happen weekly, daily, sometimes.
Yeah. The question is impact to the eyes, whether it be sports or even accidental. It can cause a lot of, collision to the eyes can cause a lot of problems. It can basically cause the gamut of problems from the front to the back. It can cause cataracts. It can also cause glaucoma, because if you can imagine, what's happening is you have normal piping, and if that piping gets damaged and it gets kinked, then the water doesn't flow through as well. So that's what's happening in trauma-related glaucoma. Question?
Is there any truth to the possibility of hereditary glaucoma?
Yes. The glaucoma is not Mendelian, meaning that it's not a mother-daughter, mother-son type of genetics. It's very complex. It's multifactorial. There's relation to your environment where you grew up, your diet, your exposure to environmental toxins, but also part of it is hereditary, okay? That we know, but how strong it weighs into our algorithm really depends on how strong the familial inheritance is. For example, there are some patients who, maybe my grandmother had glaucoma, maybe my grandfather had glaucoma, but I also have patients who say, my grandmother went blind at 50, my mother has aggressive glaucoma, my sisters and my brothers all have glaucoma. Those are the patients that I believe there is a strong inheritance pattern to glaucoma. Okay? Yes?
How do the drops work?
So the drops work in multiple different ways, but in short, the three main ways that they work: one increases the flow. One acts as basically Drano. It tries to flush through the pipes a little bit. One turns down the tap, so the flow into the eye is reduced. And the third one looks for a different outflow. It tries to look for it basically looks for a different outlet than the normal way that the fluid gets out of the eye. Yes?
What do you think of sleeping with your head elevated?
Sleeping with your head elevated can help reduce pressures in the eyes.
And what do you think of Travitan?
Travitan is an excellent medication, yes. Okay, so last myth, but an interesting one I think to end on. Marijuana is a good alternative or adjunctive treatment. It's a myth, that's why I have it on here. Not true. Also, this is the third picture that is not my own. I have never seen marijuana. I walk the straight and narrow. In fact, just a quick anecdote, when I grew up in Minnesota, we had skunks in the neighborhood from time to time. Either just in the neighborhood or the dogs would carry the skunk scent around, so I knew what skunk smelled like. But when I came to Los Angeles and I lived in the freshman dorms, I smelled what I thought was a skunk loose in the dormitory. So I went down the entire hall knocking on people's doors saying, "Look for a skunk loose in your room. We gotta catch it." We never caught one. Okay, so marijuana. So I did this research the other day. I went to a website called thepriceofweed.com, and I found that high-quality marijuana in California costs $256 per ounce. There is approximately 1 gram of marijuana per joint, I think, which makes it about $9.14 per joint that is smoked. The average length of the effect of a joint is about 2 hours, which makes it about $109.68 a day to stay high, because you have to continuously be high to have the pressure-lowering effects of marijuana, which means that it costs $40,000 a year as treatment. This is opposed to generic medication I prescribe to you, which is $15 for a 3-month supply. And I always start with generics first, by the way, because they're excellent medications. There's no need to use anything more expensive until we absolutely need it. Now, let's say we diagnose glaucoma at the average age of 50, And the average life expectancy in the US is 79. That's 29 years, which means that for your 29-year duration of glaucoma, you're spending $1 million, over $1 million on marijuana if you were using that as treatment for glaucoma. So no, it is not a good treatment for glaucoma. In fact, the American Glaucoma Society, because we are inundated with this question oftentimes by patients, that we came up with a position statement in 2009, and I will read it for you. Although marijuana can lower the pressure, intraocular pressure, IOP, its side effects and short duration of action, coupled with the lack of evidence that it alters the course of glaucoma, precludes recommending this drug in any form for the treatment of glaucoma at this time. Okay. All right. Okay, so glaucoma. Myths are done. We're going to move to the latest surgical advances as the last portion. We'll probably finish up in the next 10 minutes or so. Thank you for your patience. It's went a little over an hour. I apologize. I don't expect anyone to know where this is from. This could be anywhere, but these are some ceramic plates that were taken from a souk, or a local market in Morocco. Okay, so I have 3 short videos. These are the minimally invasive glaucoma devices, surgeries that I mentioned before. These are the things between medication and our heavy-duty surgeries that incapacitate people for a couple months sometimes, or at least the eye. These are what we have in the middle now that are good options to treat milder disease and for those who just cannot tolerate drops for whatever reason. Okay? The first 2 videos don't have any narration, so I'll narrate as you go. The third one does. So the iStent inject here, these are all, oh, before I play this, I do want to say that although these are schematic videos, meaning they're cartoons showing how a surgery works, but it does show the eye, it does show the surgery itself, but in a cartoon format. So if you feel uncomfortable, please do go ahead and close your eyes. Okay. All right. So this is a cross-section of the eye. What you're showing here is that the fluid that's being produced is not getting out of the drainage system because the drainage system is blocked. Now they show that there's this small silver device that is allowing fluid to go through. That is essentially what the iStent inject is. It's the tiny stent that is placed into the drainage system of the eye. So imagine you have a pipe that's fully clogged. We're just placing a stent with a lumen to allow fluid to flow. It's very similar to cardiac stents that cardiologists place in the heart when it's blocked by atherosclerotic disease. This is the size of the stent, okay? That's a penny, and that's the size of the stent. It's microscopic, okay? So really, definition of minimally invasive surgery. What happens is at the time of cataract surgery, we get the cataracts, we make the incisions for the cataract, and the stent actually goes through the exact same incisions. We don't create anything new. So we're not creating any extra damage to the eye as we're doing this procedure. It's a tack on to the surgery for cataract. Cataract takes 10 minutes, this takes another 5. Your whole thing takes 15 to 20 instead of 10 to 15, okay? There's 2 stents that come out. Again, that's the drainage system. We pop 1 stent in, it creates flow through that area. Then we go a couple clock hours away to make sure we target another independent area, okay? So we have 2 chances to improve the flow of fluid through this otherwise blocked drainage system. Okay. Okay, so that's the iStent inject. Again, no financial disclosures. I don't work with any of the companies. I use their products because I believe in them. The Cahook dual blade. Now, the iStent inject, the one that I just showed you, is one I like to use for patients who have relatively mild, sometimes moderate glaucoma. It can only be done at the time of cataract surgery. The dual blade is one I'll use for patients who have moderate, sometimes severe glaucoma, because it tends to have a little bit more of an effect, but with increased effect comes increased side effects, right, or risks rather, right? Everything is measured. So I do this procedure for those who either need a little bit more effect or if they failed to get the effect that we needed from the iStent. So it's called the Cahook dual blade. We call it the KDB for short. Again, it's placed through a micro incision in the cornea surface of the eye. If we do it at the time of cataract surgery, which we can, we use the same incision, but we can also do this one outside of cataract surgery. Again, a cross section of the eye so you can see what's going on. We'll create a small incision into the eye so that we can get into the chamber of the eye. We put this device, a jelly-like substance, in the surface of the eye to make sure that the eye is nice and formed as we're doing the surgery. And essentially what's happening here, you'll see, we use a specialized mirror to look at this. So one hand's holding the mirror, one hand is holding the surgical device. But it's essentially a specialized knife, a micro knife. And what it does is, instead of trying to bypass the clogged piping, it just strips it all off. Okay. So instead of putting a tube in, it's acting kind of like a roto-rooter and just cleaning through. Okay, that's about it. The rest of it is more of the same, so I'll stop that there. And the last one that I'll go through is called the Zen Gel Stent. This one does have narration, so I won't speak. It also has some very cheesy music. But the Zen Gel Stent is something that I will save for patients who have moderate to severe glaucoma when the other two are really not sufficient. Okay.
The Zen Gel stent is 6 millimeters in length, and when hydrated, it becomes very soft, compressible, and tissue-conforming. The gel stent is preloaded in a disposable injector with a 27-gauge needle. The Zen Gel stent creates a patent channel through the sclera, allowing aqueous humor to flow from the anterior chamber into the subconjunctival space. A sub-2 millimeter clear cornea main incision is recommended for the procedure. The injector enters the incision and travels across the eye to the superior nasal quadrant where the stent will be placed. Due to the ab interno approach, the gel stent is placed properly away from the iris and endothelium. The needle is inserted through the trabecular meshwork, creating a scleral tunnel to the subconjunctival space. Once the needle exits the sclera, the location is verified or adjusted as needed. The injector is further advanced until the full bevel of the needle is visible. The needle is then rotated towards 12 o'clock. This rotation helps avoid the soft stent from curling. The gel stent is delivered by actuating the slider on the one-handed injector, while the other hand maintains gentle fixation on the eye. The sleeve provides longitudinal placement control during the deployment. The gel stent is delivered into the non-dissected tenon space, creating a connection from the anterior chamber to the subconjunctival space. Its lumen is designed to regulate the outflow and avoid hypotony. The aqueous humor will begin to flow immediately, creating an ab internal bleb, which over time becomes a low-lying drainage area.
Okay, so if you didn't understand any of that, that's okay. That video is actually meant for glaucoma specialists when the first device first came out. Essentially, the take-home point for this particular procedure is if the drainage, the piping system is already so far gone that we can't bypass it, we can't cut it out, then we have to bypass it completely. So if the corollary in the heart is doing a triple or a quadruple bypass, where you're using different vessels to bypass what's completely blocked. In this case, you're using this very soft gel stent and creating a bypass from inside of the eye to outside of the eye so the fluid can drain out. Okay? So again, we use this one when we're really stuck and nothing's really working for us. All right? Okay, so that's the end of the surgical advances portion. Any other questions? We've had some, please.
How do you test for glaucoma?
A lot of ways.
There used to be where they do that other thing. Do you still do that? Or?
That checks pressure. There's multiple ways of checking pressure in the eye, although it's not the only thing that you need because some studies say that approximately 50% of glaucoma patients are missed simply because the puff test said that the pressure was in the 10 to 21 range, but there's a significant number of patients who are under that. So we use the pressure check test. We also use a machine that scans the thickness of the nerve. Again, glaucoma affects the nerve health. So if there's glaucoma, then the health of the nerve can be measured. We also do a test called perimetry. Some of you may have taken where you're looking straight ahead, you see a small light in the periphery, you have to click the button, and it's infuriating. But it helps us with our management. So a mix of testing, but not just. We don't use the puffer at our practice because it's not as accurate. Yeah, we use a different way to measure pressure though.
Relating almost to what you were saying, the nurse on the exam said interocular pressure 6 to 8. The doctor came along 15 minutes later.
Yeah.
And said no, 11 to 13.
Yeah. So that's a great.
That's
a great question. The question is sometimes the nurse or the technician when they measure the pressure is X, but when the doctor comes in it's Y, and it's different, and sometimes substantially different. Depends on the technician training. Some technicians are excellent. I have many technicians who I work with who I agree with their pressures pretty much every single time, or we're off by maybe 1 point, which is acceptable. But it's not always the case. Sometimes pressures can be difficult to manage. Trust whatever the doctor ends up saying ultimately. I like having our technicians check the pressure for a number of reasons. Because many of them are excellent, and I always double check the pressure as well. But I use it as a screening device. If I have a patient who has a pressure of 40 or 50 sitting in the room for some reason, I want to know about it immediately so I can address it instead of I'm seeing other patients. I want to go to that patient immediately to manage it because a pressure of 40 or 50 is an emergency. So I use it as a screening to make sure that we're not having someone wait unnecessarily long.
In 2018, you said 2 new medications were introduced.
Correct.
Can you tell me the names? And
One is called
Also, how are those different than previous medications, which seem like all they're trying to do is lower the pressure?
Yeah.
Is this doing something different?
Nope. The short answer is no. The 2 new medications, the question was, what are the 2 new medications, their names and mechanisms of action? One is called Vyzulta, V-Y-Z-U-L-T-A. The other one is called Rhopressa, R-H-O-P-R-E-S-S-A. The Vyzulta is also known as latanoprostene bunode. What happened with that medication is they took a very good medication, our bread and butter initial starting medication called latanoprost, and they tacked on which is called a nitric oxide moiety. And this particular addendum to that medication is thought to be able to lower the pressure through something called the nitric oxide synthase pathway. It's supposed to lower the pressure. It's still lowering the pressure, but it's lowering it via a different mechanism. And it's thought to help reduce the production of it as well. And there's some purported effects of neuroprotection where it may have some buffering role in protecting the nerve from pressures. The other one is called Rhopressa. This particular medication serves to decrease pressure in a few ways. It helps decrease pressure. This is again what the basic science studies, the core studies had showed that can reduce the formation of the aqueous fluid in the eye, which helps lower the pressure. It can increase the outflow of the fluid from the eye as well. And the third one is it's something called, it lowers the episcleral venous pressure. What that means is the eyeball itself is pressurized, so fluid can't exit the eye. It can only match the pressure of the eye. It can't, your pressures in the eye will never go to 0 because there's an intrinsic pressure inside it. This particular medication tries to lower what's called the episcleral venous pressure, or the pressure of the veins, because the venous system is what draws the fluid away from our eyes ultimately. So you can't have a pressure that's really lower than your venous pressure unless you're doing a bypass type of surgery. So it's a little complex, but they're excellent new medications. I especially have found Rhopressa to be fantastic in terms of the results.
Are there drops for allergies and to the preservatives that you take that are on the market that are getting less expensive? There's one I know of, but it's really, really expensive.
I'm sorry? The question is, are there good medications for eye allergies? And there's a lot.
The glaucoma.
For glaucoma.
Yeah, if you have an allergy to the preservatives.
Oh, okay, yes, yes. If the question is, are there medications that do not have the preservatives in case you're sensitive to preservatives for these particular glaucoma drops? And yes, every category of medication has a preservative-free or a preservative-light. It's using a lighter preservative formulation available. Yes. R-H-O-P-R-E-S-S-A, Ropressa.
Thank you.
Yes. Was there a question over here? Yes.
What about, I think it's the initials are TSL or TLS?
SLT.
SLT?
SLT is a laser procedure. It's an excellent, even first choice, because some patients, they just don't want to take drops. They live an active lifestyle and they don't want to deal with drops. Or some patients, if they're incapacitated and they cannot take drops, SLT is a good way to start. It's a laser that's performed in clinic, takes about 5 minutes, very minimal risks and side effects. Yes?
I think on that, but I'm also on post-op, and Repressa just, they just took me on it a month ago, and I have never had a pressure of 8 and 10.
Repressa has...
Always been 17 to 21.
I've had some pretty astounding successes with Repressa. I really enjoy the medication. It's helped save a number of my patients from undergoing surgery, which I know they've appreciated. Yeah. Yes?
Glaucoma inevitable with one ages, and also does it run in families?
It is not inevitable, but the risk increases. And the reason that the risk increases is, as you can imagine, if you have a sink with piping, over time it gets blocked. And so over time, our natural piping in the eye will slowly get blocked, which is why the risk increases with age, but it's not inevitable by any means. And it can be hereditary, but it's a difficult hereditary pattern, not a cut and dry one. Okay. Yes?
If a person has shingles in the eye, can that cause glaucoma, and what would you do for it?
Usually, shingles in the eye is transient, meaning it occurs once when you have the shingles on the skin as well. And when the skin vesicles go away, the eye inflammation usually goes away at around the same time, maybe a little longer, maybe a little shorter. During the flare-up, the inflammation in the eye can cause pressures to spike up high. And so during that time, we will treat the pressure spike that happens during that acute inflammation. But usually when the virus settles down, the inflammation in the eye settles down and the pressure will get back to normal. Recurrent inflammation in the eye can cause glaucoma because it causes scarring inside the eye. But shingles is usually happens once, sometimes unluckily twice. But because it happens usually once, that one episode is usually not enough to cause everlasting glaucoma. It can cause an increase in the pressure just during that duration.
But if that person has post-herpetic neuralgia,
yes,
with it, and it's gone on for like 10 years.
No, the post-herpetic neuralgia will have no connection to the intraocular morbidity. It will not. Yes.
Just a clarification
Yes.
for me. It's a myth that glaucoma is always caused by high pressure.
That is correct.
But all the meds to treat it reduce the pressure.
That is an absolutely great observation, and the reason is because we don't have anything else that we can target at the moment. The question is, not all glaucoma is caused by high pressure. There is what we call the normal tension glaucoma or the low tension glaucoma, but still all of our medications target pressure. Why is that? And the reason is because we don't have anything yet to rejuvenate the nerve. That is the gold standard. If we can find a way to rejuvenate the nerve, then we can cure glaucoma. But that research is still relatively in its infancy. So that's not available. The only what we call modifiable risk factor for the vast majority of patients is to reduce the pressure. Modifiable risk factor. We can do things like reduce the amount of steroid medications you're on, healthier lifestyle, leafy greens, exercise, etc. But the only one that we can actively manage with medications and surgery is pressure. So that's the only one we really target. There are some medications on the market for glaucoma that has a purported neuroprotective effect, especially with patients with low tension glaucoma, which is why for some of those patients I will start a medication called brimonidine first, because again, in patients who have this normal tension glaucoma or vascular compromise, the thought is that this particular medication not only lowers the pressure, but it can also potentially improve the blood supply to the nerve. So each of these medicines have little nuances to them. Every patient was different. Every glaucoma behaves differently, which is why every single patient who comes to me really has an individualized treatment plan. It's not kind of an ABC algorithmic. We kind of go in terms of what is best for that type of glaucoma, what the patient can tolerate. If you look at my notes for any patient, they're paragraphs long almost, because I document every single medicine that's been tried, what has worked, what has not worked, what has given side effects, what is intolerable. Well, sometimes I even include how much a particular drop costs, because sometimes they're exorbitant, the fees are. So again, everything is individualized. No two patients are the same, and no two glaucoma treatment regimens should be the same. Yeah. All right, thank you very much. Anyone know where this is? This is Grand Canyon. Grand Canyon, again, there was a picture on the way to Grand Canyon. This is Grand Canyon at sunset. I have one last video, if you will bear with me. This is a short one. So I thought that was a very sweet video. I'm going to share one last anecdote, and then I promise I'll let you leave. Sorry. A number of years ago, I think 5 or 6 years ago, my father went for his annual eye exam, and his glaucoma specialist picked up early glaucoma at that time, and prescribed a medication. It's called latanoprost. It's the bread and butter medication, one time at night, easy to use. And told him to start using it and recheck his pressure in a month or two. Don't know if this is common in Asian, in the Asian society, but my dad does not trust doctors. So he thought she was lying to him, didn't believe that he had glaucoma, and didn't want to pay for the medications because he thought that she was just trying to sell him something he didn't need. So he didn't pick up the medication, didn't use the medication, and 2 years went by. He was climbing up the porch steps, and he didn't lift up his foot enough, and he tripped. These are the porch that he's been going on up and down for years. And he tumbled, and he had pretty significant cuts, bruises, and bumps. And so he was very confused. Why did he trip? This is his home. It's not like this is an unfamiliar place. And he kind of just checked his vision like this. And he noticed that he couldn't see his hand. In one eye, he couldn't see his hand if it moved downwards. So basically, he lost all of his vision on the inferior part of the right eye. Okay, so that's why he didn't see that step. So he went back to the glaucoma specialist a couple years later, who was kind enough to say, okay, it's progressed a lot. It's advanced a lot. You've lost 50% of the vision in that eye now, whereas before when we caught you, you had basically lost nothing. But let's start drops. And so he started drops. And for the past 5 years, he's been rock solid steady, has not changed at all. Okay, so thankfully, thank God, what he has, he maintains. And his other eye, thankfully, is excellent. It's doing great. He shared that story with me a few years ago, a couple years after he started the medication, probably a little sheepish. And I became furious because I was an ophthalmology resident. And I couldn't believe it. I was livid. So I did the most unspeakable thing you could think, which is I became a glaucoma specialist so that I can take care of my father, but all my other patients, whom I treat as basically family members. Because that's really the only way you can practice medicine, I think, is to treat everyone as if they were a family member or as if they were yourself. Because I treat based on what I would want for my own eyes as well, okay? So that's me on the top right. I don't like to do self-promotion. This is a little embarrassing. But I did have the opportunity to train both on the West Coast at SC as well as the East Coast at Harvard. I grew up in the Midwest, and I work locally, so I'm very privileged to be able to offer care to those in the Fullerton community. All right, thank you very much for your time.